Palliative and End-of-Life Care for the Aging Population, with Nicole, Grigg, Shukri, Jimale, Fatemeh, Kazem, Tabrizi, Pamela, Makela, Krishna, Patel, and Trived. Presentation made for the University of Ontario Institute of Technology, also known as UOIT. Perspectives in Aging, HLSC 4807U course with Professor Winnie Sun. The characteristics of palliative and end-of-life care. According to Fainsinger, Demoisiak, Cole, Meadwood, and Lee, 2000, palliative care is the program to help those suffering from life-threatening illnesses. This program allows for individuals to have an improved quality of life and decrease suffering in their remaining time. It allows for individuals to choose the location of their choice for their passing, whether it be in their own family home, surrounded by family, friends, and loved ones, which is often chosen, or in a medical establishment. This form of medical care is often affordable for individuals as opposed to the cost of hospitalization. With easier access to these services, it may take a burden off of the family and friends going through the process of end-of-life care with their loved ones. Brete, El Sota, Palmer, Reddy, and Bruera, 2007, state that palliative and end-of-life care is not available for everyone with a life-threatening illness. There are certain criteria that needs to be met for those individuals to enter the system. The characteristics evaluated include age, gender, pain, illness, prognosis, state of delirium, previous medical records, and reasons for seeking palliative care. Symptoms that follow the acronym of the letters of the word pain are used to assess the patient's total pain as part of the assessment process. P stands for the physical, which includes any physical symptoms such as blood pressure, x-rays, and other scans to diagnose and monitor the physical condition that affects the patient's health. When assessing physical symptoms, objective results are usually recorded. A means anxiety. Patients often undergo various mental health issues, such as anxiety, anger, and depression, which has a toll on their physical and mental well-being and perspectives of pain. Interprofessional problems represents the I in pain. Subjective answers are recorded and compared to previous documentations. These items are known to be things such as being lonely, financially stressed, family tension, or problems which often tie into their mental and physical health. N stands for not accepting oncoming death. Through this assessment measure, it is determined if the patient is in denial with their level of pain and doesn't fully understand or want to comprehend the prognosis of their illness. The World Health Organization, or WHO, defines palliative care as an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness. Through the prevention and relief of suffering by means of early identification, an impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. These programs include all healthcare services offered to patients and families. WHO states that palliative and end-of-life care provides support systems for patients and family members to cope during the patient's illness and personal bereavement, and to support them and help them grieve. This type of care uses a team approach for patients and families for counseling and bereavement. WHO also states that palliative and end-of-life care also incorporates relieving pain and other distressing symptoms, affirms life and dying as a normal process, integrates psychological and spiritual aspects of patient care of patients through the process of dying, as well as emotional and physical symptoms. Hospice is a part of palliative care, but palliative care is not hospice. Hospice is care offered to those in the last 6 months of their life.
The aging population in Canada is increasing, and according to the Canadian Hospice Palliative Care Association 2015 fact sheets, seniors could account for 23 to 25% of the Canadian population by 2036. It is also estimated by 2061 there will be 11.9 to 15 million people over the age of 65. With the increase in the older population, the healthcare system will encounter a greater frequency of chronic, non-communicable diseases such as various forms of cancers. Currently, approximately 74% of seniors over 65 have reported one or more chronic health problem. Moreover, the demographic trends will present with an increase in death rates. According to StatsCan estimates, by 2020, death rates will have increased to 33% from 2004. With this rapidly emerging trend in aging, end-of-life care and palliative care is starting to be a key player in healthcare delivery. The patients often consist of older individuals who are experiencing terminal diseases or severe discomfort, and they require relief from their condition. Because palliative care plays such an important role in delivering end-of-life care and making the transition for the patient more comfortable, lack of accessibility to palliative care for seniors because of limited resources can be an issue, as they are not receiving proper timely assessment and treatments for their health problems. Let's consider this scenario. Almost half of known cancers occur in patients over the age of 65. From this group, there is a 66% mortality rate. Oftentimes, cancer patients over this age of 65 will be using palliative care services. However, lack of accessibility to palliative care could inflict pain upon them, and there is evidence that suggests being over the age of 70 is the greatest risk factor for increased pain. Palliative medicine has developed as a separate medical discipline and has become an integral part of the healthcare system. This type of healthcare does a better job both by performance and by financial measures when compared to the type of care delivered in acute and intensive care units. When the average cost of acute and intensive care units are compared to the cost of palliative care in Ontario, palliative care also demonstrated significantly lower costs when it came to healthcare delivery. This is primarily due to the reduction in excessive pharmacological interventions which are used for curative purposes, and an increase in provision of comfort care for patients. Mortality rates were significantly lower in palliative care units, and the report published by the CHPCA suggested if patients from acute care units and ICUs were transferred to PCUs, the system could potentially save significant dollar amount. A day in an acute care facility costs approximately $1,000 to $1,200. While a bed in palliative care unit in a complex care facility would cost about $300 to $500. There is strong evidence from the studies done by the CHPCA that suggests palliative care units and palliative care teams can reduce the cost of hospitals by $7,000 to $8,000 per patient. The cost of dying in 2002 and 2003 was nearly $25,000, and it is substantially higher now. Expanding palliative care services to accommodate patients will reduce the financial exhaustion and will also put them in a comfortable environment where they are surrounded by their loved ones. For this research, external validity can be extended to everyone in Canada who receives palliative services, as well as the provincial and the territorial governments that see the financial benefits of palliative care services as their total expenditure is decreased for the services rendered. Studies have also shown this to be true for healthcare delivery on a global platform. For its internal validity, from the study conducted by the CHPCA, there is high amounts of certainty that palliative care teams and units deliver care that is financially efficient and beyond satisfactory for patients. There is a strong correlation between the expansion of palliative care services and increased cost savings. Research across all fields of palliative care emphasizes the importance of educating individuals about the end-of-life care. Nyatanga 2015 focuses on educating individuals that lack the knowledge of the process of palliative care and end-of-life care. The author takes into consideration factors influencing decisions that are made at the nearing end of life. Palliative care allows family members to safely care for their loved ones undergone through a stressful time dealing with taxing symptoms. Keeping in mind, palliative care is not only for patients, but it is also for the families and the friends of the patient who are undergoing through similar hardships. Palliative care unit plays a major role in allowing them to get the treatment they require. Included in the article, there is a list of guidelines for healthcare providers to improve the quality of life for palliative patients while outlining medications and procedures depending on the situation that may arise. Such clear guidelines are crucial as they reduce excessive medical interventions and play a greater role in focusing on patients' comfort and symptoms. For palliative services to grow in the future, it requires further financial flexibility to increase resources and accessibility. Right now, the federal spending is divided into 3 categories: primary, acute, home and community care. As funding allocation is steered towards primary and acute care models, it is not a reflection of what the population needs when it comes to end-of-life care. To meet the demand of long-term care services, the Canadian Centre for Policy Alternatives concluded that the provincial and the territorial government need to allocate greater budget parameters for long-term care services, while keeping in consideration the shortages of bed, facilities, and equipment for end-of-life care facilities. The external validity of this research can be generalized to the population in Canada that is recipient to palliative care services funded by the federal government and delivered by the provincial and territorial government. The internal validity of this research takes into consideration the progressive improvement of healthcare delivery from the past, maturation, and mortality amongst population. The causal relationship is not dependent but rather subjective to the amount of time that is allocated for the remainder of an individual's life. So now let's talk about ways in which we can improve palliative care services. The first and foremost thing would be to raise public awareness. It is one of the strongest strategies to improving end-of-life care and allowing people to recognize what the patient's medical, social, and spiritual needs are. Oftentimes, patients are not in the position to express themselves or make decisions. For the person making decisions for the patient, it can be a potential lack of information that can prevent him or her from exploring this option. Also, in order to increase public awareness, informative conferences and campaigns are organized by the government, private organizations, and are open to the public and the healthcare professionals to learn more about the advancements in the field of palliative care. For example, the CHPCA National Hospice Care Week occurs during the first week of May, where they further continue their efforts to promote palliative care in Canada. Internationally, the World Hospice Palliative Care Day is organized by the World Palliative Care Alliance. Another method in which palliative care can be transformed is by expanding the services to isolated communities. This will not only allow the system to add more healthcare professionals, it will also enable it to provide patients with dignity and autonomy that they deserve. Furthermore, by adding more jobs and expanding palliative medicine, facilities can start forming interprofessional teams that can provide patients with holistic treatment to improve their quality of life. Lastly, to improve palliative medicine, adequate resources and funding must be made available by the provincial public authority. For example, in Ontario, that would be the Ministry of Health and Long-Term Care. These resources and funding must be used to help facilities develop the necessary leadership, staffing, and staff training and education to provide high-quality palliative care for the patients. The media can be an empowering tool to inform the public about palliative care and reduce the potential stigma around the issue. Oftentimes on television, palliative care patients are portrayed as elderly, which is an accurate representation of the individuals who use the service. However, it is not limited to the elderly. They often portray pediatric palliative care and even show young adults who are near their end of life. Social networking websites can be used as platforms to promote the benefits of palliative care. It can act as a place in which discourse about the issue can occur. Important information can also be given out. And lastly, positive stories from families and friends can be shared. This is really important when we talk about removing stigma about the issue. It's simple. The more information that is shared, the lesser stigma there will be around the issue of palliative care. In efforts to demonstrate the positive side of palliative care, CBC's medical podcast, White Coat Black Art, illustrates the importance of palliative care through the stories and informative blogs written by Dr. Brian Goldman. This is an important aspect of educating others, as there's several misunderstandings and preconceived notions about the end-of-life care. And when the audience hears it from the patient's family and their friends, they tend to have a better understanding of the experience that they had. And it's usually a positive experience, as the family and friends get to spend their last moments of their loved ones talking about pleasant things, talking about happy things, and telling them that they love them and they care about them, whatever the situation might be. It's usually a positive one. Even primetime television, such as Grey's Anatomy, which is a really popular medical show, it shows the benefits of palliative care. In several episodes over 10 seasons, 11 seasons, they show terminally ill patients passing, with the doctors being there in support for the family and friends. And the way they portray the death is dignifying. It's empowering. It doesn't show the weak. It doesn't show the person who is dying as someone who's weak, someone who is tied up with tubes and intubated. But it really does shed a positive light on passing away in the arms of people you care about. So the media is definitely heading in the right direction when it comes to portraying palliative care. Although I feel more work needs to be done in this department, and I think it starts with the new generation of doctors who interact with the patients' families and interact with their friends, and just having an open conversation about what palliative care is, what the benefits will be for them, and for the patient. So to conclude this presentation, I'd like to say that palliative care does go beyond healthcare delivery. It is a service that takes into account the patient's mental, physical, spiritual, emotional state. It also considers the family and the friends and what they're going through. The support that each team would provide for the family and the patient is tremendous, and it really sets a very empowering environment for both parties. And as the patient inches towards the last few breaths of their life, it really gives them dignifying moments, and their last breath is taken with dignity, with pride, and with love. It is not only good for the patient, but it also has many financial benefits, as discussed in this presentation. The healthcare system definitely can save a lot of tax dollars should they choose to expand the system and substitute it with acute care and intensive care. Last but not the least, when a patient passes away, it's a very peaceful passing, as the last breath is taken in the arms of family members and loved ones. And if any of us had the choice to live out our last few breaths, it would definitely be in a similar fashion. Thank you for watching our presentation on palliative care.